All right. Well, welcome everyone. We've got a really good crowd who's already zoomed in, and this morning is going to be a bit full, so we might as well get started. Welcome. So thank you for joining us this morning. My name is Oleg, and today I'm joined by Amber, and I'll just ask her to unmute and put her video on.
Sorry, I'm trying to start.
That's okay.
Can't seem to start my video.
Oh, all right. Well, whilst we wait for Amber to start her video, might I just say that Amber and I, we've worked together at Te Whatu Ora County's Manukau, at least over the past almost 3 years. Welcome, Amber. Hi. We've worked at Te Whatu Ora County's Manukau almost now for 3 years, and we've been the leads implementing shared goals of care across the entire organisation over the time. So we've learned a lot about shared goals of care, as well as about implementation project work, and we thought this morning would be a valuable opportunity to share some of our experiences with you. So let's move to the next slide. So I'd first like to start by inviting Amber, if you could, to offer us a karakia.
Sure. E te hui whae te mautauranga kia marama, kia whae ka takina mahi katoa. Tu maia tu kaha araha atu araha mai, tato ia tato katoa.
Thank you, Amber. Kena maunga whakahi, kena wai tuku kiri, kena mataraka o te motu, ka nui te mihi. So tēnā koutou katoa, he uri ahau no tāwhati, ko haina te whenua, I tau aku te pina, ki ranga I o tautahi, ke mihi ahau ki toa whenua me ona ori, ke mihi au ki te maunga kiki, ke mihi au ki te awa hopua, no anihanga o hau, ko Oleg toka ingoa, no reira, tēnā koutou, tēnā koutou, tēnā koutou katoa.
Koutou katoa, ka mihi au ki te maunga manaia, ka mihi au ki te awa hatia. No whangarei ahau, ko Amber toko ingoa, no reira, tēnā koutou, tēnā koutou, tēnā tātou katoa.
So the whakatauki I wanted to use for this morning and has guided us through this entire process in the work we've done in Minimal Hospital is he wakaeke, because I feel it really encapsulates what we've strived for at every step of the process. And today is no different, I feel. You know, we've used every opportunity to bring people's awareness to shared goals of care and understand why we believe it's such an important process to ensuring good patient care. So we're grateful for being given this opportunity to talk about shared goals of care with you this morning. So do keep this in mind for this next hour, he wakaeke. So the outline for today will first focus on what shared goals of care is, and Emma will help me with this because she's in actual fact the true expert. Then we'll talk about what we've done at Middlemore Hospital and what our next steps will be. We've also prepared a case history as an example of how shared goals of care works and how it can guide people, you and me, as well as patients, through potentially really tough situations. Amber and I will then be joined by Dr. Celia Palmer and Patricia Gosper for a panel discussion. We invite participants to ask any content-related questions by using the Q&A function at the bottom of your screen, and we'll be answering all the questions at the end of the session. If we run out of time, we'll send answers out in follow-up emails. If you have any general questions or comments, please use the chat function and we'll aim to answer you as soon as possible. So let's start off with our first poll, just to get a sense of where people are sitting. How much do you know about shared goals of care? A, I've never heard of it. B, I've heard of the term but don't really know what it's about. C, I understand what shared goals of care is. D, I'm familiar with the HWA shared goals of care program in New Zealand. And E, I've been involved with shared goals of care in New Zealand at a clinical level. I'll just give you a moment to answer those questions before I ask Willow to show us what the answers are, what the responses are. Shall we see what the responses are, Willow? Right, so I see the majority have said, I've heard of it, but don't really know what it is. So that's great, because today will be a real learning opportunity for everyone. Awesome. All right, well, let's get started in that regard and figure out what shared goals of care might actually represent. So shared goals of care is a national program led by Health Quality and Safety Commission. Over the past, I'd say 7 years, would you say, Amber? And it's the third. Right. It's the third work stream of the Deteriorating Patient Program. The three components really are the New Zealand Early Warning System, EWS, the Korera Mai, or Call for Concern Patient and Whānau Escalation process that's available in hospital, and finally, obviously, Shared Goals of Care. Shared Goals of Care is now incorporated into the National Advanced Care Planning Program and is administered through that branch. So, first and foremost, I guess, what is shared goals of care at the clinical level, though? We always say that a starting point, in my mind, should always be the conversation with the patient in their whānau, sitting down with them and simply having a kōrero. And it's, I guess, from this experience, when we have a shared understanding of each other's thoughts and feelings, when we know what each other understands about priorities and preferences, then we can truly engage in a process of shared decision making. It necessarily has to involve the patient in their whānau, as well as clinicians. And this is what separates it from advanced care planning. It also requires the clinician to explicitly explore the patient's values rather than framing the discussion in a biomedical way. Recognizing that we're actually quite poor when we talk about values and inquire about values, often we lack the skill to match a values-based approach. This process incorporates the Serious Illness Conversation Guide as a tool to help facilitate these discussions. This then goes on to inform the treatment options that best align with patients' values, beliefs, and preferences. And should the patient deteriorate during an episode of care in hospital, hopefully, if they've engaged in this process, then there'll be more clarity and agreement on what the most appropriate goal of care would be it curative, restorative, improving quality of life, or indeed comfort whilst dying. And not that we really actually need it, because I think shared goals of care is simply good clinical practice, but there is a strong and compelling case for change. Acute deterioration can often happen at any time, especially during hospitalisation, and recognising this early, planning for it and responding appropriately improves patient outcomes and satisfaction. It's especially important that this work is prioritised and done early during an admission, as often these are the periods of greatest risk for patients when they're at their sickest, at the first stages of an admission. Suffice it to say, if we don't do this, then patients then go on and deteriorate. They may well get care that's not aligned with their wishes, low value care that perhaps does more harm than good. So that's exactly what we had noticed and was experiencing in Murumore Hospital those years ago. patients at high risk of deterioration or death were not being identified. And even when we did recognise them, goals of care conversations either had not been done or were done poorly at best. Over and over again, there have been cases where patients in their whānau experienced poor outcomes because of low value care. And there just weren't the systems to support clinicians to make a difference, even if they were motivated to do so. Overall, perhaps the biggest problem we encountered was the culture wasn't particularly fit for purpose. The culture didn't particularly practice patient-centered care and didn't support goal concordant care very well. But a lot of these factors, as you can imagine, aren't unique to Miramore Hospital. Amber, can you talk us through some of the key factors we discovered and presented to our executive leadership team? Now, what were the reasons why we really recommended shared goals of care be adopted with some urgency at Miramore?
Thanks, Oleg. I think initially around our resuscitation decision making had been regularly identified by the deteriorating patient group that there were either decisions not happening or decision making that really didn't recognise the etiology of deterioration or the comorbidity in terms of the people who were attempting to be resuscitated. And of course, outcomes within hospitals are pretty poor with CPR anyway. Our Amber and quality of death audits really, as you said, highlighted that poor communication of goals of care. And this obviously can lead to either increasing inequities, we're not recognising early palliative care needs, and therefore people are being referred late. Ministry of Health audit, we had a corrective action here where really they felt that the decisions sometimes were documented, however there was not a discussion there to inform how that decision was made. So for us that was another national incentive to get this work done. The health and disability complaints, 15% of those relate directly to communication, which is a really high number, and we wanted to see how we could support better communication for people. Plus, we were also getting shared goals of care forms that were being sent in by the community from the ARC, which was great.
Yeah, which was great, but which we just simply didn't have any ability to attend to or know what to do with exactly. And I guess this next slide, yeah.
Just an example, I guess, of a retrospective audit that was done 6 months post deterioration and then death, and just looking at any form of goals of care, advanced care planning, referrals to palliative care. And what it here identifies is that Māori, again, received the fewest of those goals of care discussions, which, of course, then perpetuates those inequities.
Yeah, really highlights the equity issues, doesn't it? So why aren't these conversations already occurring then? What did we find?
Really, our system is under a lot of pressure. And so, of course, we know that timing makes a difference, the way we communicate, the language that we use, and the way that we frame these. Our own beliefs and our own distress in having these discussions is also a barrier. And of course, the system challenges where we are really set up to try and prevent actually these happening within the system that we currently have. So all these barriers are very well documented and evidenced across international literature also. So we're not unique in that sense. And as Oleg suggested earlier, fundamentally this does require a shift in culture and a system that really supports change. Recognising, I guess, too, that initially we thought this was sort of going to be RMO implemented, but SMO led. And I guess this really does look at requiring a really interdisciplinary approach, I think.
Yeah, Yeah, it's not as simple as that, is it? It's quite a complex, situation we encountered. A whole lot of different moving parts in coordinating everything was quite a challenge. So ideally, if it is effectively implemented, embedded, what would you see as the benefits that shared goals of care could hopefully achieve?
I think this is really looking at being able to guide our team around how we support patients for an episode of care. Really better experience for the entire team, including patient and whānau, that knowledge of what's happening and relatability to their context, their worldview. Being able to have a single process that supports across the whole of the organisation, tools that are very familiar. We have a regional approach, so therefore when our workforce move through the different hospitals and region as they rotate, these skills can go with them and they don't have to learn new processes. So it's just building and developing on those skills. And the electronic health record increases that visibility, that ability to see things changing over time and build on conversations that have happened prior. So that really enhances our confidence and enhances the patient and whānau experience by recognising that the discussions they've had prior still are able to be built on and recognised as value. And as we said earlier, really sort of an MDT support for this. So utilising all of those different touch points and skills and connections that we have within the health service. Yeah, we're hoping to ensure that the care that we deliver is high value care that's wanted and warranted, really sort of trying to minimise any additional harm, particularly as patients nearing end of life. Our aim really is we want to really proactively align clinician goals, really thinking about what's appropriate, as well as aligning those with patient and whānau goals, and thinking of this as a focused advanced care planning discussion that evolves and moves with the trajectory and the condition that people are living with. We want to be able to focus on providing that appropriate care and thinking about what we can do rather than what we won't do. And that also agrees that direction of care for an episode of care and reflecting and responding as we go if there's changes. So our aim of this is that approving recognition of patients at risk of deteriorating and dying and improve our communication to develop shared goals of care for a better experience.
Thank you, Emma. And I guess, at a practical level, the actual process of implementation, could have been quite simple, just simply exchanging the paper CPR decision resuscitation form with the electronic form. But we took the opportunity to actually also incorporate a whole number of other local counties' forms, including the treatment escalation plan, the Ambicare pathway, the Manawanui care of the dying pathway, EPOA documentation and ACPs within the shared goals of care form. And this is what we arrived at in terms of the electronic form that's available through the snapshot portal on Concerto. And as you can see, this section here is the discussion section. And this section here mirrors the Serious Illness Conversation Guide and is a free text for clinicians to document. We've also got a history section where you can actually inquire on previous shared goals of care discussions and documentation. This is the actual decision itself, goal A, B, C, or D. And these are the parameters that can either be available or not available depending upon what goal is chosen. And this is the Serious Illness Conversation Guide. We consulted with Tikahui Ora, our Māori health team. Emma, can you talk us through the key changes that were made to the national form to ensure mana whenua needs were being met?
Sure. So the original Aotearoa Serious Illness Guide went through a process of co-design at its original development. And further consultation, as Oleg said, we had incorporated more overtly the HWA process, which if we look at that prepare section there, the HWA processes are being developed out of Otago Medical School to enhance the relationship between Māori and physicians. And this HWA process has been taken from tikanga protocol in terms of engagement, really looking to set up the conversation well, build a connection, build a rapport, and signal the intent of the conversation. The second part was really around ensuring that people had support, recognising that the need for empowering within a hospital setting, ensuring that people have the right opportunity to have cultural support, whānau around them. So being really explicit and asking and making sure that people know that that's okay to have that. And some of the language was also changed a little bit, just to make, in terms of that meaning and sentiment, much more clear.
Yeah, a very valuable process in learning for us at Miramore. So, having done all that preparatory work, we finally plan on going live on the 1st of March this year. We were unfortunately delayed by a couple of months because we hadn't appreciated there were some elements that were still needing attention. And it's interesting how this situation evolves in real time because it really perhaps, highlights at least some of the difficulties overall that we were experiencing. And we encountered very many difficulties and barriers and have had to find workable solutions in order to move the project forward. There was a high prevalence of late adopters, which meant no service actually wanted to be used as guinea pigs. And the solution to that really was a hard launch across the entire organisation all at once, which ended up being the 1st of May. The constant refrain about the lack of time meant we needed to make the most of whatever time was given to us with high quality and high impact interventions. Another concern was moral distress, as Amber touched upon, and poor communication skills. So it was important to point out that we offered empathy training and that the tool itself is patient-centered and clinically safe in all areas of practice and at all levels of competence, right from the novice in terms of first and second year practitioners through to the expert. And finally, the culture shift that was needed in order to, bring the process through and get over the hurdle. And it was a big hurdle, truly a big hurdle to overcome. But anyway, thinking about our whakatauki, he waka iki, we always emphasise that the discussion be more important than the actual decision. If you have the discussion, the decision will eventually follow. And so keeping that in mind kept us sane. I just wanted to spend a little bit more time talking about what we felt to be the biggest learning for us, and that was really appreciating the need for a change in our culture of practice. We know shared goals of care represents the gold standard in terms of shared decision making. The dilemma was, how do we embed it into clinical practice? We needed to make sure clinicians first understood it and then be provided with training to gain the skills to use it. And that's not an easy feat. That meant training was our single most effective lever. And we had to create a culture change through training. But how do you train hundreds if not thousands of clinicians. And I think, Counties Manukau has about 3,000 clinicians, doesn't it? Well, we worked hard at making training accessible to all. We went to the teams and worked around their busy schedules. We adapted the training to various lengths, formats, levels of proficiency, and used case scenarios relevant to them. We also promoted it widely through all the media channels available internally. And we were proactive and opportunistic, much like this morning's session. And we recognised the need to capture minds and hearts of the clinicians so they became motivated and prioritise this work. An important part of that was recognising the apprenticeship model that clinicians use to gain clinical skills. SMOs needed to be the role models, and these behaviours were then, hopefully transmitted through to their juniors. So that was an extra challenge, trying to get the SMO teams on board. And this became a repeated process of engagement, because we needed to go back to the executive level so as to obtain and renew our mandate on a regular basis before returning to the teams and engaging with them individually again. Hard work. Oh my goodness, such hard work. But unfortunately, there is no shortcut around it. It needs be. Before implementation, we also took the opportunity to completely write a new set of policies and procedures, and that was actually quite a useful exercise in clarifying the roles and responsibilities. And as Amber did almost entirely the entire body of work in policies and procedures, I'll let her explain in terms of what the roles and responsibilities actually amounted to.
So again, we recognise that this can be supported by the entire team. So we have groups of professionals that are able to complete the decision side, and that is where the SMO is holding of the responsibility. A registrar and nurse practitioner are able to complete the decision side, and yet all of the clinicians, allied health, nursing team, when they've undergone training and utilising the tool, are really able to support the discussion side. So this is where we can look at how we might support early integration of these discussions and link that information to support an informed decision. So it requires all of us to be facing the same way and supporting the same way, and utilising all those different members within the interdisciplinary team.
Yeah, and that was a big lesson for us, because in actual fact, how successful do you think we were in that process at the ground level?
Not that successful to start with, were we?
No. Well, there were so many other factors at play. Firstly, obviously the COVID lockdown really scuttled the project, but then the winter workload, which isn't confined to winter these days. So many pressing priorities, so many other projects vying for clinicians' attention, workforce capability, rostering, all these factors had to be taken into account when thinking about these roles and responsibility, not only responsibilities, but capacities as well. What is that clinician's capacity? And being compassionate to the actual clinician and accepting that, they are burdened, they are stressed, they are at their wits' limit.
I think what we were heartened about, though, was the fact that the nursing and allied health were seeking out this training and were really keen to support a much more connected way of understanding people. And so we're really keen to be involved.
Yeah, absolutely. Yeah. So let's move on to the case example. So I'd like to introduce you to Mrs. T, a 62-year-old Māori woman, married with one daughter, who enjoys large whānau support. She's also the full-time carer for her husband, who has a chronic health condition, and was admitted herself with acute kidney injury following a 2-week illness with fatigue, bloating, and altered bowel habits. A renal ultrasound showed large ascites, and the CT showed bilateral effusions and extensive metastatic disease. She was eventually diagnosed with stage 4 ovarian cancer, and as you can imagine, on admission, she was scoring quite high on her EWS. Her early warning score consistently was greater than 6. But a CAM, her confusion assessment method, was negative. So knowing that, if you're the clinician who's facing this patient and her family, what do you think is the appropriate shared goals of care? Goal A, treatment aims to prolong life. Goal B, treatment aims to prolong life and enhance quality. Goal C, treatment aims to control symptoms, enhance well-being, and should be easily tolerated. Or goal D, treatment aims to relieve suffering in the last hours to days of life and allow a lateral death. We'll just give you a moment to answer those questions. And then we'll just get Willow to share what your responses are when she feels the majority have responded. Goal C, oh my goodness, I'm preaching to the converted here. Great, fantastic. Well, what do you think the actual clinician did? Oh gosh, sorry. There we go. So the clinician actually chose goal A on the shared goals of care form. And that was, I guess, identified as a risk when the patient was subsequently reviewed, in the need for actually a shared goals of care serious illness discussion was identified. Amber, can you run through what was discovered, what was disclosed during that conversation?
Sure. So initially we went through the HWA process in terms of establishing rapport and consent for the discussion. Utilised some te reo to help make a connection and assess where things were at in terms of her identification. And recognised she was originally from Northland, as was I, and so we were able to make a connection there. Part of this section, the setup, is to make sure that permission and that we had support established before progressing. Then we were able to assess how much information she wanted about what might be ahead in the future, and actually what the understanding was too of where things were at for her now. The second, this section here, the share section, was where we were able to support and provide a more meaningful prognosis that would help her to frame what things were happening for her and actually lead in before we led into the next lot of questions. So for Mrs. T, we used the prognosis of uncertainty. She was clearly unwell. Things had happened quite quickly. She was in the early stages of her diagnosis. So we felt that this would provide that ability to recognise what had happened. Things had become unwell quickly, and that it would be helpful to sort of consider and plan for the possibility. When we were able to share that resonated very much with Mrs. T in terms of how things had happened for her. So the explore section, where we're able to ask questions around priorities if health does get worse, worries around thinking when health's changing, what helped her through strengths. We were able to really sort of understand that the priorities for Mrs. T was really about managing symptoms. She had a long-term partner that had been with for a long time and wanted to marry. And that included being at home with him. She had been her main carer as he had been injured in an accident, and she did worry about how the family would cope and how he would be cared for. She referred to her whānau as her core strength, and these were the people that she required and helped her get through those difficulties. Now, the critical abilities is really sort of thinking about the things where I can't imagine what life would be like if I wasn't able to do this. And for Mrs. T, she said none. So long as she was with her whānau, she felt that she would be able to cope with whatever life threw at her. And when we asked the question about how much you're willing to go through for the possibility of more time, she said she was willing to go through anything. And she wanted her treatment to be aimed at keeping her alive for as long as possible and wished to have received all treatments that the healthcare team thought were appropriate to that situation. And also when we asked around what her whānau knew was important to her, she said that they were very involved in her care and decisions, but they weren't all aware of her diagnosis, and she wanted to be able to share that with them in a formal herself, and then have a formal meeting with the team to discuss that further on what might be ahead. So really entered into a partnership about what was important to her, how she might want that care to look. And that was really helpful for us to be able to sort of direct the next steps and engage in that conversation around escalation management while in hospital. So our recommendation, this section here means that we're able to sort of elicit the things that are important and reflect those back to make sure that we are hearing correctly, that we are aligning that plan. And for Mrs. T, it was around having a subcut infusion to help manage those symptoms, including PRN pain relief, manage the nausea and vomiting, and that was weaned off prior to discharge when symptoms were well controlled, managing the bowel regime and supporting until that kidney injury resolved. She also had our ascites strains and dietitian involvement, and that continued on in terms of the community support to try and build up that nutritional background again. So the support that was ongoing in terms of carer and whānau support, so NASC involved, making sure that it was a care package for her partner as well as for herself, and that did delay discharge, but that was important to ensure that that wraparound and that peace of mind and prevent readmission. Part of this following close is around Porapora Aki, which is around that next step. So to ensure too that that the person knows what's coming next, so it's not just the discussion and done, but actually what's going to happen as a follow-up.
Thanks, Amber. So a lot of insights there gained through this conversation. And reflecting upon that now, what do you think is the appropriate shared goals of care? Once again, the same options, A, B, C, or D. Do appreciate this is a brand new, fresh diagnosis. And she had initially been goal A without the discussion. Where do you think the goal has moved? Let's see what the results show below. All right, let's have a look at the results below. Interesting. Wow. So a lot more goal Bs. Yeah. So, Amber, what actually did happen?
So I think we're able to support an adjustment to the goal of care, recognising that actually, even if she had deteriorated there, that she was not an ICU candidate due to the disease burden, but that because she wanted to have everything that was appropriate, the goal of care was changed to be, and she was accepting of that. And we also looked at facilitating an advanced care plan, which was a really empowering process for her and her whānau.
Oh, absolutely. And I think, let's not forget that changing from a goal A to a goal B is fundamentally important and is a huge shift in terms of the approach to care. As you highlighted earlier on, when we did the resus audit, we found how many 25 out of 32 or 35 resus attempts were inappropriate. 25 resus attempts were in patients like Mrs. T, who were by default made goal A, and who had had a 777 pull because of deterioration. And so changing from goal A to goal B fundamentally is important. Just wanted to stress that fact. But I think this case also highlights, in my mind, a little bit of confusion between goal B versus goal C. Everyone knows what goal A is for resus, and everyone is comfortable and understands what looks like a goal D, end of life. But it's the B and C that people find difficult to discriminate. So what would you advise clinicians who do find that challenging, Amber?
Thanks, Oleg. So the SPIC tool, the Palliative Care Indicators tool, is really helpful to recognise the patient that may have deteriorating health. This tool has been designed to assess and identify people who are likely to be in the last year of life based on their non-clinical indicators and clinical indicators of deteriorating. We advise to sort of review this when thinking about goals of care, particularly for patients who, once in hospital, are much more high risk, if they're recognised on this tool, much more high risk of deteriorating and dying during admission. So ensuring that the care is easily tolerated, the interventions are easily tolerated and not going to add additional symptom burden and suffering is a really key aspect to that. Really thinking about deterioration prior to admission into hospital and what that was looking like. Increased carer fatigue, weight loss, in a chair more often, as well as end-stage disease. So the combination of those things can help identify those patients who are much more at high risk and the type of interventions that are really going to add value opposed to increased burden.
So anybody, in a nutshell, who's SPIC positive should by default be goal C. Yeah.
And I think that's really recognising that actually we're still providing active care. We're providing care that is of high value to that person. It may not have all the bells and whistles on it, but it's recognising actually where someone is in terms of their trajectory. And I think in an acute setting, sometimes that can be very challenging where you've got a lot of things that can be offered.
Yeah. In the sense that clinicians feel that, changing from A to B, B to C, C to D is in actual fact somehow giving up or disappointing. That's in actual fact not the case. It's actually the opposite. It's being more attentive and being more engaging. So let's move on. So it's been implemented at Counties Manukau now, and it's been a few months that it's been live. What are the next steps for the project team at Counties Manukau.
So we're looking at doing a ward pilot in a medical ward, and also looking at supporting a outpatient surgical pilot as well, just to sort of assess the use in those two settings. The e-form can be accessed in the community as well, and so that outpatient setting is somewhere where it's timely, people have time to think about these things, and it can build on, which reduces the pressure when someone's admitted into hospital. Also, a ward pilot gives us an opportunity to look at really that interdisciplinary approach and utilising the different skill sets and time where people are on the ward to engage in these discussions and build that less siloed approach to this work. We're continuing on with our regular training and bespoke training, and of course with our Click app, we're able to do a bit more of a deep dive into what's happening.
Yeah, absolutely. And now that you mentioned Click, let's just focus on the Click app and see what it's all about. And so because it's an electronic form, we're able to keep a very close eye on traffic through the form. And this has really been transformative as we've never really had access to this level of data in the past. In the past, it was paper-based, and the only way of auditing was through manual paper-based audits, and that just completely did your head in. And it only occurred sporadically once every few years, whereas the Click app has allowed us to look at the form live in real time, and this is the homepage. This is the dashboard, and as you can see, this is the number of forms completed per day, literally, and we average, about 80 forms a day. There have been a total of almost 17,000 shared goals of care forms done. No, am I reading that right? No, 17,000 discharges, and of those, about 7,500 have had a shared goals of care form. We're able to drill down according to service, according to other patient parameters, ethnicity, and so this has been a very useful tool for us to look into. And through it, we've actually found some intriguing aspects of practice which we were not aware of in the past. And I really wanted to highlight these four and ask Amber to talk us through them individually. So the first one.
This shows that we're sort of 65% of patients admitted with a length of stay greater than 2 days have got a shared goals of care decision. So that does align actually with our paper audits, and so we're looking at actually increasing that, recognising that these decisions and discussions can also help us with readmission. And so if we get into that opportunity of engaging people and thinking that this does help us guide a episode of care and inform rather than just a tick box, I think we are going to see an improvement in that.
At least it's reassuring that we're not doing any worse than what we had been doing with the blue resuscitation form in the past.
Yeah. This is 12% of all of the decisions that have been done. 12% of those have had a discussion, which means that only 12% of those decisions have been informed by a documented discussion. There may have been discussions that have occurred but not documented, but we would like to see them in here, as this is a single source of truth and ensures that all other clinicians are able to find the information easily. So we'd really like to see this increase significantly.
Oh, up to 100%, which is why we're now focused on a ward-based re-implementation, so as to bring the discussion section up close to 100%.
So this gives us a breakdown of all the goals of care percentages for people who have got the decision, and you'll see that the majority are sitting with goal A. And I guess, when we talk about a shift in culture, this is representative of that. That again, that we think about what we're expecting in terms of CPR. When we just tick goal A, are we actually depriving an opportunity to think a little bit more and then understand what matters to someone and think about the etiology of deterioration? We would expect to see larger numbers in the other areas considering our population and the complexity. This does include women's health as well, so there would probably be more people within this, but we can break it down much more. It's still always A is the highest number.
Absolutely, and women's health would only skew the data a little bit, and so this is brand new information and awareness for us, and we don't have any benchmark in terms of the proportion that you would expect in a general hospital population that would be goal A. But I would expect for an acute hospital like Middlemore Hospital, where only the sickest and most comorbid people present and are cared for, I can't believe that 70, almost 3/4 would be goal A. So it seems a little bit unbelievable, but this is the clinician's practice we're looking at.
Part of the process is that actually to ensure that the decision is appropriate, I guess, around what the goal of care is, that the SMO is actually overall responsible, and therefore part of the form is that the SMO is informed and if there's had a discussion. So this is ticked either yes or no, and this highlights, I guess, how much involvement the SMO has had. So the blue 82% identifies that most of them have not been involved in this discussion or decision.
And that's a bit concerning because that does potentially suggest a fundamental breakdown in the relationship between senior staff and junior staff, that the SMOs are not aware of these decisions, that they're not aware of what's happening under their watch. And so we've talked a lot about the hospital setting. We've talked a lot about Middlemore Hospital. What about the community? What's the relevance? What's the focus on in terms of the community, Amber?
So I think this is an opportunity for people to see a more meaningful understanding of what might have happened within an acute setting. Enables people, as I've said, to build on those discussions, to support much more timely understanding of a person's values. We can use these in perioperative or dialysis units and outpatient care. So it makes it a much more visible single source of truth, as we said, and look at that whole of system. There is a shared goals of care designed for aged residential care, so that ability to also inform vice versa as well. And of course our SIG, we can support community teams in the community, with our training and things, to be able to go out into the community where their power imbalance is much different, the pressures are different, and be able to support those discussions in a much more comfortable manner. So these are the tools developed by Health Quality Safety Commission, and you can see that they all interlink. The Advanced Care Plan is a person's own plan. It can be supported with a healthcare professional or completed with whānau. The Serious Illness Conversation Guide helps facilitate those discussions, or it may help in terms of a shared goals of care discussion where we're really around focused and specifically around an episode of care.
Fantastic. And that pretty much brings us to the end of our presentation. A little bit over time, but we do have a few minutes for question and answer session. So I'd like to invite Patricia and Celia as well. And Celia will be moderating the Q&A session. She's had her eye on. Sorry, you go, Celia.
Thank you so much, guys. That's obviously an absolutely huge amount of work, and I just want to recognize that and how much commitment you must have made to make that happen. Some of you guys might be wondering how we came to present this particular topic around Middlemore at Hospice West Auckland webinars. Well, you might not know that Oleg Kiriaev, who is our one of our SMOs and works with us 3 days a week and at Middlemore 2 days. And it was really helpful sometimes to, I think, understand and know we at the hospital, it's sometimes like a big chasm between hospital and community. And we do have lots of things going on in this space in the community, and it's really good and useful to know what's happening in the hospital and how that connects. And so it was nice as well to see your last 2 slides. I know we haven't got much time, so I've got a couple of questions that I thought one came in at the beginning saying, is there a plan to roll out this to the community? So I don't know if that's something, Amber, you want to take up on a bit more. I know some of your last slides might have addressed that.
Yes, so there is work that's being done to support GP practices and recognising that the shared goals of care exist, putting this in discharge summaries to facilitate those handing over sections that might have been started in the hospital, supported by GP. So the tool and the Serious Illness Conversation Guide, and as I said, the ARC Shared Goals of Care form can support that population in the community. Certainly in terms of handover of information too about what decisions have been made in the hospital, how that might support care in the community is really helpful as well.
That's great, thanks. And I know that some of the tools, for example, I think SPICT might be quite familiar to some people in community settings, maybe even more so than in hospital settings. So a question for you, just to bring you in, Patricia. I know people wanted to explore a bit more of that overlap with ACP and what this means for the ACP and how that can work together. I don't know if you wanted to comment on that and the implications for us.
Yeah, thanks, Celia. I think important to note, ACP and the shared goals of care obviously working together. ACP is something that I think can be started earlier than a lot of people think it can, because it really does go alongside people making their enduring power of attorney and their last will and testament. And I think it's really important because it helps people to start this whole conversation about what really matters to me in my lifestyle and my idea about what I need in life and what really worries me. And I think those are the 2 really important questions that when people are saying, oh, how do I introduce advanced care planning? Well, it's fairly straightforward, because people do want to talk about those kinds of things. And if we start at the very basic level, what it is that matters to me, we unpack this whole thing quite easily. But I think it's just that skill really of just sitting with somebody, and also looking at the Hei Waka Kakarauri Māori ACP guidelines. I think, thinking about this person, this case that we looked at, could have been very helpful to just introduce this on a cultural level. So, yeah, that's how I feel about being able to start the conversation, and maybe ACP can lead into shared goals of care really well.
Thanks, Patricia. That's really helpful. I like the way you commented about what worries you. We often talk about what matters to people, but it's nice also to sometimes that's the other side of the coin, isn't it?
Yeah.
What worries you?
Totally.
So, Oleg, I realise that we're coming to the end of the webinar. So did you want to make any last comments, Oleg?
Yes, there was, just before we do, there was one last question. What do you do when a patient requests B when the clinician believes its goal A is appropriate? I'd say the short answer to that is the patient trumps the clinician. The goal would be B in that regard. But any last comments? Yeah. So I think, I would say it's a fundamental need that we have to change our culture of practice. We need to evolve, we need to keep up, we need to respond to the needs of our community. We need to have courage to do so. We need to be in full-heartedly ask what matters most to people. It's not that scary. Their life context is everything. We need to find out what their life context is in order to make sure that our treatment plans match that.
Thanks, Oleg. And I like your comment about the patient trumps and I think that definitely we find some things are quite challenging for us in terms of patients wanting everything when our perspective is that's not helpful, or the other way around. And I think walking alongside people, making sure that we know what they want and reach those shared goals of care is where we're going. So thanks very much everyone for joining us this morning. We'll answer some other questions in the follow-up from the webinar, and we'll go to the closing karakia.
Kia whakeere te tapu kia wata ai tiara, kia turiki whakataha ai, kia turiki whakataha ai. Hui e, tai ki e. Thank you.